everybody as we're letting everybody in. It's lovely to see everybody and welcome you to our last COBRA for the academic year. This started as an idea that Prithvi and I had about finding ways to educate trainees, fellows, young attendings, and just talk through a process really kind of geared towards fellows. And I'm kind of excited that it's, I think, gone pretty well. We've gotten some nice comments, and I think our fellows have been happy. Prithvi, you haven't been yelled at yet?
The complaints have been surprisingly low, which is good.
That may change tonight, who knows?
Right.
But given how fantastic this has gone, I'm happy to announce we'll be doing this again next academic year. And I believe Prithvi has a tagline for COBRA 2. I can't wait to hear about it. And probably just as importantly, we're going to be doing this live in person at AAO on September 30th. If you look at the COBRA website, there'll be announcements, there'll be email blasts, and we look forward hopefully to seeing a number of you in person. With that said, first, I'd like to thank our supporters again, Bausch and Lomb, Bausch for supporting the COBRA education program, and they will be supporting us next year. So we look forward to even more educational material. And obviously thank iVista for all their work. Prithvi, take it away.
Thanks, Neil. End of the academic year for many of us. We just had our graduation ceremony this past weekend where we recognized our graduating fellows. We gave them a diploma and then we took it away because we didn't want them to stop working for the next 3 weeks. But we're very proud of them, and I'm sure many of you are in that position too. So what we decided to do is to kind of capstone this first season of COBRA with kind of for the graduating fellows, what has been their worst case, their best case, or their worst case that they learn the most from. So, these are all very humbling scenarios, and we've actually gone through a spectrum of, looking at complications and different types of surgeries, but we thought we'd leave it, kind of dealer's choice tonight and let the fellows decide what cases they wanted to kind of roll with us. So we're not quite sure what we're gonna get tonight, Sunil, so we can get started.
All right, thanks, I'm excited. Do you want to introduce or want me to introduce? I'm happy to do your job if you like.
Oh yeah, well, thanks for keeping me on track. So we'll first start with the delightful team from the Cole Eye Institute in the Midwest of the United States, Cleveland, Ohio. Our mentor this evening is Dr. Sumit Sharma, who I know oh so well. Sumit is a uveitis specialist at the Cole Eye Institute and a retina specialist. It is training at the Duke Eye Center and has been a important contributor to COBRA. Sumit is going to be moderating tonight. So Sumit, do you want to introduce your graduating fellow if you let your fellow graduate?
He's going to graduate and then he's going to stay on and spend some more time with us. So nice. Danny Mamo is our current second year VR fellow, and he's actually joining our faculty coming up very quickly here. And Danny will also be doing uveitis and VR starting soon. And so we're very excited to have him stay on. And Danny is going to start us off with our first case. So Danny, go ahead.
Thank you, Sumit. And thanks to all my mentors here and also to the Stanford folks for the COBRA rounds. It's been a lot of fun. And I look forward to future sessions as well. But all the teaching so far has been priceless. So thanks to everyone. Today, I thought I'd present a case that we don't do too often. I thought that it gave some nice teaching points for me, and it's something we don't see. So I wanted to get everyone's thoughts on it. So this is a case of a young 38-year-old male who came to us as an outside referral urgently for a retinal detachment in the left eye. And immediately when you look at this eye, it doesn't strike you as a standard rhegmatogenous detachment. Inferiorly, there's some subretinal fluid leading to retinal corrugations. Other than that, it looks like there's a lot of choroidal effusions. Inferiorly, a lot of subretinal fluid there. The other eye was totally normal. On OCT, the right eye has a thick choroid and a mild lumpy appearance, but otherwise normal. The left eye has these deposits on top of the RPE and there's some subretinal fluid. We don't see any vitreous cell on exam or on the OCT, and the choroid looks pretty thick. He's 2150 in this left eye, and his vision's been down for a few weeks in this eye.
So Danny, what are your thoughts of this? So actually go back. So let's go back to your previous slide. Here you go. So when you see somebody like this, how do you kind of approach this patient and what are you thinking about?
So first looking for a break, it was referred for rhegmatogenous retinal detachment, but there was no pigment. The story didn't quite fit. So then I'm starting to think of other causes of, choroidal effusions, whether they're infectious or inflammatory. We're always going to order these infectious labs, but he didn't really have any risk factors for any infections. There also was no sign of inflammation. There was an FA I didn't show, which didn't show some significant vasculitis. I'm more concerned about other causes of uveal effusion. Is it's neoplastic? He's awfully young for that, but it's possible. There was no history of trauma. He was not very hypotenuse, another cause of effusions. He doesn't have any hardware around the eye.
Can we clarify something here? I get confused. So when you say effusions, were there choroidals, like choroidal effusions, or are you saying that the effusions are the kind of bullous exudative retinal detachment? Like what do you call effusions? Maybe I'm not catching that definition for you.
Yeah, I think you can, sometimes it's synonymous, but this case is mostly a case of choroidal effusions. On exam, the fluid extended past the aura. It has that lobular appearance that we saw on the fundus photo here. Inferiorly, where there's these retinal corrugations, there was also superimposed subretinal fluid, which you can get with choroidal effusions and overload of the RPE. So this case we felt was a predominantly choroidal effusion case. So the differential of that is what went on in my head. He was hyperopic. So we got a scan and B scan to look at his axial length. And his axial length was on the shorter end. It was 21.2 in this left eye. So not qualifying for nanophthalmos, but on the shorter end. So ordered some basic labs, which we assumed to be negative, and they were. And we started the patient on steroids. Dr. Mrutyunjaya, I know, what is your thoughts on how often steroids work if this is a case of uveal effusion syndrome?
The Shields group published a study of many patients that they treated with steroids, and they had a very small percentage of patients that went on to needing surgical intervention. That would be 100% the opposite of my experience. So I think that unless there's truly a treatable inflammatory cause, I haven't found that steroids have been helpful. I wish that they were, in this condition, but it just hasn't worked in my hands. So I think I've tried, and I've been, kind of going to, heavier dose oral rather than, trying to do like periocular to see if I can get a faster effect and make a decision sooner. But I think I spend some time trying to get them better with steroid, but I think that time is becoming less and less.
I like how Danny pimped you on that one. That's
because he's ready to be done. It's like a bold move.
That was amazing.
I just wanted to get the thoughts from our oncologist and
the nonchalant Cleveland.
I was hoping he was going to say Durezol. That's what I was hoping you were going to say.
So I think
I just know you've published on this technique, and I just wanted to because my experience here seeing Sunil and Sumit treat these patients has also been similar to yours. I feel like many of these patients don't have the dramatic improvement that was cited in that paper that's commonly cited by the Shields.
Yeah, and again, it's hard to know what the what each of these patients look like actually when they come in, and in this case, this looks pretty classic for it. So thick choroid, the other eye's thick. I think you can try steroids, but I think you're probably going to need to do some intervention otherwise.
So we had this patient come back a few weeks later, and his subretinal fluid actually resolved, but his effusions did not. And what you can subtly appreciate, and you could see it in OCT macula as well, is that his inferior subretinal fluid was getting a lot worse. It was approaching the arcade. It actually extended into the inferior arcade, and his choroidals were measured a little bit larger on B scan as well. So the decision was made to proceed with scleral windows. So another question I had is, I feel like I've seen a few of these cases now, and as the cases progress, you get this leopard spotting pigmentation as you get these changes in the RPE. Are those irreversible or reversible, or do you think earlier intervention is necessary to make sure those changes don't happen in the macula and lead to irreversible vision loss? What's the experience of the faculty?
I'll say that getting a autofluorescence on wide field is nice now because you may already have those changes in place. I think the problem with this condition is that the referral and diagnosis is often delayed. So this could have been brewing for a long time and then became acutely symptomatic when fluid came into the fovea. So sometimes you'll be surprised at the extent of how much leopard spot changes may already be there. I don't know how much they improve. I've seen some focal hyper autofluorescent areas maybe reverse themselves, but the hypo autofluorescent spots usually, they're not going anywhere.
So we decided to produce scleral windows, and this was my first case. We started not showing it. We did a 360-degree peritomy.
So actually, hang on a second here, Danny. So let's actually go one step back. So what are the other things that you mentioned ruling out infectious and inflammatory causes? What other things do you want to rule out in a case like this? So what are the things that are important to think about?
So CSR can rarely present like this. He had a thick choroid in both eyes. He did not have a history of steroid use, and the FA was not really suggestive of CSR, but it's in the back of our minds. Definitely would think of it more if he got a lot worse on the 60 milligrams of prednisone. TB and syphilis can cause this, and sarcoidosis as well. Choroidal lymphoma can present this way, but atypical in his age group. And then obviously there's 3 types of uveal effusions syndrome if you rule out everything else, which we felt we did in this case.
Yeah, so some of the other things to think about are the other eye. Yeah.
I'm sorry, what was that?
Is there any leaks in the other eye or any autofluorescence changes? Because this could all still be CSR. Atypical.
No, the FA was normal in the fellow eye, and FAF was normal as well.
Sumit, do you scan the body looking for some mysterious neoplastic process in this case?
Not necessarily. I think it kind of depends on the individual patient. So I tend to get a scan if they're more solid looking choroidal changes, right? So if you're B scan, so what I was getting at with Danny is, I think the other things to look at and rule out is you got the B scan and look at the B scan and make sure these are really serous choroidals, and that they're not actually a solid mass that's masquerading as a uveal effusion. Rule out any prior surgeries causing either hypotony, and it can be subtle. It can be like the pressure in the other eye is 20 and this eye is like 8, and that can actually cause some of these changes. So ruling out prior trauma as well that's causing a ciliary body cleft, because that's the other thing that can cause this type of picture, and the treatment would be different. But once you've ruled all those things out, then the next step, I agree, is often doing scleral windows. I tend not to scan every patient for full body. Prithvi, do you?
No, not really, unless there's some history.
Yeah.
Great. And also some medications you think about too, right. But he was not on any medications. So we tagged all the muscles as we would for a buckle, and then we isolate all the quadrants. And our goal here is to start about maybe 3 to 4 millimeters back from the insertion of the recti muscles. But in reality, we're looking for where the vortex inserts into the sclera. And ideally, you kind of want to get close to that insertion to theoretically, they talk about de-roofing that insertion where the vortex enters the sclera, or sorry, exits the sclera. So we want to make a 5 by 5 window here. So we're marking with calipers. And then I'm going to start off by using the crescent blade. And this is the first quadrant. And so I'm a little timid here, not wanting to go too deep. And one of the nice lessons in this case is that we actually use intraop OCT to gauge the thickness of that first bite, which when you start making your plane, it's harder to go deeper and find a new plane. So it's nice if you get that first bite correct, and then you start your plane off at a nice depth. And here, if you look, I was too thin, much too thin in the sclera. You want about 75% thickness to start your plane. So I went ahead and back with the crescent blade and made a deeper incision, partial thickness, of course. And then I never used this instrument, didn't know we had it. The 57 blade was very nice for these tissue planes. So I'm grabbing one end with a 0.12 and then using the 57 blade to dissect and try to keep the same plane throughout. And at this point, you're going to look for a blue tinge to the sclera to know you're deep enough. But you don't really see that blue tinge on the initial pass with the crescent blade, which is why I thought the OCT was kind of a neat trick to help with this.
Sumit, do you
nice
try
when you
to
don't
unroof
accommodate.
Sumit, do you try to unroof the vortex veins? Like I don't think I've really done that.
I haven't really done that either. So, when I start this, because of the depth part, I really like there's a diamond blade where you can set your depth to whatever you like. And I really like using that and setting it to a set depth and using the intraop OCT to really see kind of how thick the sclera is based on that. And that helps set the depth. You can use the crescent blade, but I really like the diamond blade plus the 57 blade like you used here. I haven't specifically gone after a vortex before.
I tend
to go mid quadrant.
I changed my technique a couple of years ago and started aiming towards the vortex because that started making a little more sense to me of what I was trying to do. I mean, if you believe this is congestion, you want to relieve the congestion at some level. So I'm not saying it's completely correct, but if we are in it, near it, it gives me an idea of how far back I want at least the posterior part of the window to be. It's hard to unroof and it's scary, and you can do some damage. So when you first do this, I would probably stay away from it, and it's okay to be less aggressive because you can always come back. But as I think I've gotten grayer, I've done a little bit more where I've encouraged this, and Danny will tell you it is a little nerve-wracking to do it the first time. But I think it makes sense to me if you really believe that this is a venous congestion problem, a vortex vein congestion issue, you kind of want to decompress it. So that's why I've kind of aimed more towards it. I'm not saying it's 100% correct, but that's at least how I think of it.
Danny, did you find your second, third, and fourth quadrants were either easier or you're more confident on thickness? I find that first quadrant's always thinner than you want to be in terms of the flap, and the others tend to be better.
Yeah, I think that definitely would have happened were it not for the OCT. As you can see here, the depth actually ended up pretty good here, but the other ones were definitely, much less nerve-wracking, I think, once you have that sense of making the flap with the 57 blade and keeping that same depth for sure. So then we do the same thing in the 3 other quadrants. I'm going to show one more here. So 5x5 window again, using the crescent blade. And then here again, this was a little deeper than my first pass, but I used OCT again to make a deeper cut. And then the same technique with the 57 blade, just a different angle. And this patient was phakic.
Is that the vortex there that you're unroofing?
Yeah, that was the end of the vortex there. And then here's a post image showing a nice depth as well. He had very thick sclera, as we can predict in many patients that have this syndrome. So we've performed the windows in all 4 quadrants now. And now we're going to go to the inferior quadrants and make sclerostomies with a Kelly punch. So I go back to the crescent blade, and here I'm making a partial thickness cut down until I see blue choroid. At this point, Sunil pulls for another timolol, and I take the decimase punch, and we release choroidal fluid. So here's my first teaching point. At this point, the eye gets pretty soft given all of this release. And this is a phakic eye in a 38-year-old. And the eye was very soft. So, reinflating with BSS here was not as easy as you can imagine, given how soft the eye was. And he's phakic. So that was also kind of a nerve-wracking moment for me. I think Dr. Shrivastava actually will do a phaco in these cases to get access to the AC. I think, I don't know how you manage these, Dr. Sharma or Dr. Mruthyunjaya, but I was thinking of maybe filling up with visco before doing these sclerostomies. How do you guys avoid hypotony in these cases?
I haven't seen that happen, where there's that sudden gush release. That's a new one for me. I think I would pass out too. I'm not sure where all that fluid came from actually, because ideally, you're just trying to release some of that, like the outflow resistance, if you believe the theories behind it. And yeah, I'm not sure where all that fluid came from. Was that in a quadrant where you had a very lobulated serous choroidal? That would be one thought. But typically, like in a uveal effusion case that has exudative detachment, but not so much the bullous serous choroidal detachment, I haven't experienced that. Do you think you went into the choroidal, the serous choroidal?
Yeah, that was on purpose. I guess I forgot to mention, we knew pre-op which areas had the most bullous effusions based on the pre-op bead scan from our sonographers. And then I think actually Sunil had me take the indirect and look as well, just to make sure. And so we purposely targeted those areas, and they both ended up being inferior.
So if you're trying to release the serous choroidal detachment, then I think I would have had a AC maintainer or something in place. If you were just trying to release that resistance at the sclera to allow for the fluid to kind of work its way out, then I typically don't. So maybe that's the difference.
That makes more sense.
When I put AC maintainers in the phakic eyes, what I find is that the AC gets really, really deep. And I worry that if you leave the AC maintainer in, it's going to whack the lens. So sometimes what I'll do is I'll make a para and I mark the para, and that way I can refill with BSS at any point in time or fill with viscoelastic. And in a lot of these patients, at least in the older ones, since they're phakic, I just make them pseudophakic at the time of surgery and then do this. And I found that works as well. In Prithvi, I purposely drain the choroidal effusions. I find it makes this thing get better faster.
The other thing that I'll do is if it's a very bullous detachment, again, theoretically, the mechanism will work, right? You release that scleral resistance and that fluid will work its way out. But I've also then put in a maintainer and then stuck a needle through where I am and basically drained the subretinal fluid down, which kind of expedites the resolution of the exudative detachment, and then you still have the window in place afterwards. But I haven't gone after I guess I just haven't seen them with such large serous choroidals and the exudative detachment.
So yes, we decided to go after the other bullous area, and given the heart attack this time, we did take some of the suggestions here, and we did now that we had a deeper chamber, we reinflated with viscoelastic, and I think we also had an AC maintainer available if we needed it. So here I'm amputating the scleral flap, and then we're going to repeat the same thing in the other inferior sclerostomy. So partial thickness cut down to the blue choroid. Sorry, go ahead, Dr. Mruthyunjaya.
Yeah, any tips you had on the Kelly punch?
So this does not capture the heart attack moment. I think it was this one or the last one. But the Kelly punch is not as easy as it looks. You really have to get down to the choroid with the sclerostomy, with the crescent blade. At first, I didn't get deep enough, and it was difficult because you don't want to push, because you don't want to just get a give. But you really have to make sure that you're deep enough, but not too deep with the crescent blade to get the Kelly punch in there. And then, a small bite is really not going to work. You have to get the bottom lip underneath the sclera and then maintain firm pressure to maintain the bite. But I also recommend having a firm grip because I feel like it's easy to give and maybe go into the eye more than you need to. So you have to be pulling up at the same time, but not pulling up too much that you're going to take the lip out of underneath the sclera. Is that your experience?
Yeah, couldn't agree more. I mean, I think that's perfect. I think getting under that lip is, that glistening of the uvea and then kind of getting right underneath it. Otherwise, you can create this this lamellar sclerostomy, right, where you'll have this thin layer of scleral fibers over the uvea. You think you've made this big circle, but you haven't done anything at that point. So I think you do need to get in. I think yes, be ginger with it, but I think you can lift up. I'd rather kind of lift out rather than push in. So once you get under the lip, lifting up and then making the punch, I think that's okay. I haven't seen too much trouble with that.
Good advice.
Yeah, I mean, you can see that the brown of the uvea. It's very clear. That's
exactly.
Perfect.
And there, when we saw that red tinge, we were worried about hemorrhage. So I got the indirect and looked, and there was no hemorrhage, thankfully. And then here we stick an AC maintainer in, but we didn't leave it in while we had the eye torqued because of the issue of him being phakic, as Sunil mentioned. So then we put it in right afterwards to reinflate the AC. And then we amputate all 4 scleral flaps. We actually sent them to histopath just for academic purposes. They talk about the 3 types of uveal effusion. And as predicted, they basically came back and said that it's abnormal thick sclera. So he had a very nice response. So you just close this like a buckle. So on post-op month 1, he already had smaller choroidals and resolved inferior fluid. And then most recently on post-op month 5, he's 20/40 and all of the effusions have resolved and there's no more subretinal fluid. There are these persistent hyperpigmented patches of likely RP hyperplasia, but the macula looks pretty good. And then his OCT looks very nice. But as you can see on the infrared, there is still some effect of having the chronic effusions that likely won't go away, but thankfully he has a good visual outcome.
Yeah, I haven't found that the pigmentary changes ever really go away or the OCT SLO image changes really go away, but their vision can do really well.
Yeah, it can take up to a year to get your max vision. So I find even though he's 20/40 right now, I think in like 6 more months, he'll get closer to 20/25 and such. It just takes a while, and that's when the other eye occurs. You do really well on one eye, and then the other eye will pop up. So Danny, was this the moment you decided that you wanted to do uveitis and retina?
No, I think that was the moment that I saw how quickly syphilis patients got cured.
Yeah, that fluid busting out was kind of scary.
Very cool. Why don't we go on to the next case?
Our next case was presented by our team here at Stanford. I'd like to introduce our mentor this evening, Loshan Liang. Loshan is the chief of our retina service at the Palo Alto VA Medical Center, and he's a inherited retinal disease specialist as well, and he sees patients and looks at a lot of ERGs for us here at Stanford. Awesome teacher and even a better friend. Our first fellow presenting is graduating, will be finishing with us here and joining the staff at Wilmer as the Associate Chief of Service, Dr. Kapil Mishra. So Loshan, Kapil, take it away.
Great, thanks, Prithvi. All right, good evening, everyone. So mine is pertaining to a 70-year-old male He was referred for a recurrent retinal detachment in the left eye. He presented originally to an outside specialist with a few weeks of decreased vision. He has a history of cataract extraction in both eyes and LASIK. So before he presented to us, he presented to an outside specialist and underwent a vitrectomy with silicone oil. And we didn't actually have this op note until later on, but I just thought it would be interesting to kind of read it out just briefly. So from the op note, the specialist notes that a PVD was present. The temporal and central retina was noted to have white pallor. The central macula was noted to be off and under tension with striae. There were 2 star folds noted in the temporal mid-periphery. There was a shallow choroidal detachment present temporally and inferiorly. And then they go on to say 1 retinal hole supero-temporally and 1 horseshoe tear supero-nasally. And then using diathermy, 2 areas of star folds were surrounded. Using the vitrector, a focal circular retinectomy ×2 were created where the star folds were present. And I think it was helpful to have this op note to just kind of see this part right here, because it really came into play in terms of our surgery and the planning. So other eye was okay in the right eye. Left eye was 2300, pinhole to 2070. And so this is an ultra wide field photo of the concerning eye. You can see that the media is clear, he's under oil. The macula seems to be attached, but there's several star folds inferiorly. And just temporal to the macula, you can see that this is probably consistent with where they created a focal retinectomy where a star fold was in the temporal macula, but with laser surrounding it. And this was concerning because it really restricted us in terms of real estate of what we were planning to do with our surgery, just considering how posterior that area is temporally. This is an OCT. It shows some cystoid spaces centrally and but attached, relatively where the fovea is, and then temporally there's subretinal fluid. So I'll go on to the video. The video does not include the buckle, but we placed a 41 band.
So a couple, just before you start this, what was your pre-op surgical plan? What were you thinking about, and what sorts of things were under consideration?
Yeah, I mean, we had noted also preoperatively that there looked like there was foreshortening anteriorly, so we wanted to place a buckle. But in terms of what to do with the PVR, we wanted to peel as much as possible and try and avoid having to do a retinectomy in that area, because with all the PVR inferiorly, we didn't want to have to create a smile retinectomy. And so the goal was to peel peripherally, but also centrally as well, and trying to relieve any pre-retinal traction. Just pretty much save as much retina as possible and live to fight another day. Because if by doing less, maybe initially, if we were to go back for a second surgery, then that's when we would have to sort of sacrifice more retina and create a larger retinectomy. So we were trying to see what we could get away with. Any thoughts from the faculty on what they would look at initially, or
Yeah, I think we were all probably remarking on how posterior that retinectomy is, and I think you're right on. That does make things a little bit more challenging for you. And hindsight is always 20/20, but hard to know what it looked like pre-op or before the initial surgery.
Yeah, that was why it was nice to get that op note, because originally when we saw that, we kind of gave them the benefit of the doubt that like maybe there was a really big break there or a stretch hole or something. And but it seemed like it was maybe more intentional of kind of removing these star folds with focal retinectomies, which maybe in hindsight was not the best idea.
Yeah, I mean, these cases are always tough. So
yeah, it's a hard situation, right? If you stayed attached, then it'd be success, right? It'd be fantastic. But when they don't, then, and you inherit them, then you're like, well, now everything is harder for me because your decisions are dictated by what has already been done or not done.
Yeah, but as you know, in the middle of surgery, if it's not flattening, what else are you gonna do, right?
Yeah.
You just stick oil in and just say, I'll deal with this later, or you can really go for it, and it's hard to fault somebody.
Yeah, totally. So we're doing the buckle is already placed. We're doing a 25 gauge pars plana vitrectomy as he's pseudophakic, just so you can point out. He's under oil, so we do a silicone oil removal with the VFC. And then we're looking here, this is sort of similar to what we had noted preoperatively. We're putting triamcinolone and then making sure that there was a good vitrectomy. Initially, a PVD was already present. He was already vitrectomized. And this is kind of the reason that I wanted to show this case, is because this is where I got the best visualization of a contracted vitreous base and an anterior loop PVR. This was under the tutelage of Prithvi, where he kind of really pointed out this 3D sort of opacified structure where the vitreous base normally is, and the goal of unzipping this to actually help with this foreshortening. So that we spent a lot of time just sort of meticulously kind of opening this up. We stabilize the posterior pole with some perfluoron, add more triamcinolone, and then it's just this sort of meticulously. I know it may be a little bit tough on this video, but just finding this plane where we're trying to open it up, and you may sort of see some moments where you see a kind of a line right here, and that's us unzipping it.
Hey, Kapil, can I ask, was this patient phakic at this time already?
Pseudophakic.
Pseudophakic. Very good.
Would you have taken the lens, Neil?
Yeah, always. On this kind of case, I would, just because of exactly what you're describing. And in a phakic patient, I would know in a pseudophakic, there are schools of thought, depending on what part of the country you're in, you take the lens completely and remove it. I haven't found that makes a difference, at least in my hands. I find that careful anterior base dissection, like you guys are doing, I think is the most important thing, and taking your time. And love how you're stabilizing the retina with the perfluoron. Love how you're staining as much as possible. I love the depression by your attending, which is usually mediocre at sometimes. And I think it makes a huge difference at getting this. So the key here, regardless of protocols of like PVR and such, is taking care of this portion, right? Because you have true contracture. So if you don't relieve the contracture, it doesn't matter what you put, what kind of protocols you use pre or postoperatively. You have to do this part correctly. So this is the most important.
So devil's advocate, Loshan and Sunil, why don't you, if you're going to cut it, like, why waste all this time? I mean, do you need to do all this if you think you're going to cut?
So for me personally, yes, because I think that there is anterior loop also implies anterior to the pars plana, which usually leads to ciliary body or ciliary, so hypotony for me. So I think it's important to release this traction for that purpose. I mean, I'm thinking long-term in these patients. And in some cases, you're surprised that you don't have to do a retinectomy. You actually can reattach this retina because you put a buckle on and because you've dissected. So, sure, I think you can say, all right, I'm just going to go and remove it, but there's a longer term play here that I think it's important to kind of take the time here.
Yeah, I agree with that. I mean, there's definitely an argument for doing a little bit more here. So, obviously the more you go into an eye later on, it gets more challenging. And so if you can potentially avoid that hypotony risk and everything that Sunil was talking about, I think you're better off.
And Kapil and I tried to draw out where we thought the retinectomy would go in this case with that very posterior, original retinotomy, and it didn't look pretty. Like, it was just really, really, it would shorten everything down. It's not pretty.
Yeah, and can I ask, what are you using? A couple, I'd see that you have, we're using a lighted pick. I couldn't tell, I'm sorry. You were using a, just your light pipe and cutter, or did you have any sort of pick to help like kind of elevate it?
Right now, it's just a cutter, but I'll show a little bit later. We did it by manually using.
Yeah, cool. I don't mean to steal the thunder. I apologize.
No, not at all. Thank you for the comments. I wanted to question. You had mentioned about taking the whole lens, so that would be the zonular complex, the bag, all of it, if they were phakic.
No, if they're phakic, I make them pseudophakic or aphakic, and I'll leave the capsule. And again, that's contrary to some other people in the country who say take the whole thing. I think it just, and I think in a case like this, like if I saw that it was coming really far anterior, that would be a reason for me to just take the whole bag complex. And so in some of these cases where I'm not sure, we'll do the phaco, and then I'd say, well, don't put in the lens yet. Let's go look before we always put the lens in. We put the lens in at the end. So I do this part in order to help myself out, because I think you need the view for dissection.
Perfect, thanks. So just carry on with the video, just continuing to do pretty meticulous shaving and unzipping of this vitreous space. We would take out a Tano and trying to grab any of these pre-retinal membranes that were a bit wispy, but trying to create an edge here, seeing what's available. Take out the PFO and decide to do some peeling more posteriorly, trying to grab an edge somewhere here.
Do you consider putting in some dye?
We do, yeah, so we do pretty shortly.
Sorry.
And this was a long case, so we had to scrape the cornea here.
That's a positive Prithvi sign, scraping cornea. That's usually it.
That's an average Prithvi case right now.
That's used phacos. You should have seen him as a resident.
So we're actually getting a really nice edge here, but now we go to a bimanual forceps in one hand and the lighted pick in the other.
So Kapil, to Prithvi's point, when do you decide to stop?
You know, we were getting good pre-retinal dissection. I think we just sort of keep going. I mean, I guess if the view is really starting to get compromised, then you do have to make some decisions. And so far, the view is a little bit better than what the video is showing. So we just, you continue, we're getting sort of these nice edges. The retina is appearing a lot more mobile and less contracted. And we just wanted to spend time together, Prithvi and I, so kept it going. So brilliant blue we put in posteriorly, and using a flex loop, we were able to get a nice edge here and do an ILM peel.
Is anyone trying to purposely peel ILM in your PVR cases these days?
I think that's a really good question. And people talk about this a lot, and it takes a lot of time. If I have someone who's had like a couple detachments and I just find that they form PVR super quickly, sometimes I will peel in the macula, but I don't standardly. But I'm interested to hear if anyone else is.
I haven't, I don't have the case volume to tell you that it makes sense. But I think theoretically, if we're saying that the ILM is going to be a scaffold for reproliferation in some of these, like you said, Kat, like, multi-surgery PVR cases, I feel that if I can get ILM off, and I feel better using blue rather than green from the safety standpoint, then maybe I can protect the fovea, right? Like maybe there's some protection that I'll have instead of a secondary, even if it's not like really bad PVR that redetaches, but maybe that secondary ERM that would come up ultimately won't. So I don't think I can tell you for certain long-term what happens in my hands, but I think I've tried, and it does also help in this case. We wanted to really be sure that everything was off, because it's not always easy, and sometimes it just adds a lot of time.
Yeah, I'm in favor of doing it though. I've done it. I think the reasoning is sound, but again, I also don't have a large enough end to say whether, I think it's always a good idea.
And I think it's sometimes really tough to do when the retina is really bullously detached too. So if it comes easily in these cases, I think it's reasonable to attempt. The challenge is how large do you make it, and how far out do you keep trying to peel the ILM? And there's some videos that you'll see online where they talk about just going out as far as possible, but I haven't been successful getting out past the macula with it.
I can't do that.
Great, thanks all. So we're continuing. We got out to a little bit past the arcades. This is doing it a little bit under PFO, and then so what we decided is we felt like we got enough of the traction off inferiorly to avoid having to make a retinectomy, like a 180 degree. But there was still some intrinsic traction we felt temporally, as well as some breaks within this area temporally. So we created a sectoral retinectomy, just maybe flanking the prior posterior retinectomy, which you'll see here. So this is kind of a wedge shaped, 2 to 4 o'clock. And we're not going more posterior than what was already done, but just kind of going around it in some sense.
Yeah, we kind of leave the most posterior part that was taken as kind of incorporating it, I guess.
Hey, couple, did you try to flatten it completely with perfluoron? Did you do that first, or did you to see if it would lie flat before you made the commitment to retinectomy?
I would imagine so, because I think that's sort of what I was taught, but I didn't put in this videos. Sure. But I would think so that he did. Yeah, just to test the waters in a sense. Well,
sometimes it appears one way, and then you flatten, and all of a sudden, it's clear that you actually did. It actually will flatten. It actually will settle down, and maybe you're making a retinotomy instead of a retinectomy.
So we're removing the anterior retina here. Now we're filling it, the complete vitreous cavity with perfluoron, and then doing a laser barricade around this retinectomy, as well as
we felt really dirty by not going 180, like doing a sectoral retinectomy. It felt really. We didn't talk for a while after that. It just.
Well, the other thing was I made some breaks inferiorly in a couple spots. So I thought how many breaks do you make inferiorly where maybe it's worth incorporating that into a retinectomy? But I think we got away with it.
This is like, how many licks does it take to get this in a rotational pop? It really depended until who the surgeon is and what you're doing. So I think Prithvi wasn't making an inferior retinectomy after you did all that peeling. It wasn't happening.
Yeah. He'll make it next time when I'm not looking.
Couple, when you did this retinectomy, or when you were planning out the retinectomy, do you feel like you did just enough, or more than you needed, or like was it just enough to get what you needed, or do you think you did maybe 20% more? That's always the thinking of whether how much retinectomy is enough retinectomy, and Prithvi obviously brings up the point of not doing more.
Yeah, I think it was probably a combination of what was the area of looked like good viable retina. So it was pretty ragged, kind of at around 3:30, 4 o'clock, and just beyond that, maybe there were some breaks sort of at 5 and 6, and but we wanted to keep it tight there, because once you're getting to the clock hours of like 5 o'clock, 5:30, and all that, then it's just sort of an uncomfortable place to have the edge of the retinectomy. So there's sort of those kind of factors that kept us inching more towards 4 o'clock, and it seemed to be enough. So this last part is a direct PFO silicone oil exchange. This is a backflush cannula where we're taking off the silicone tip. And I just really like this technique, doing a direct PFO oil exchange. Essentially, we remove the infusion, and we're putting the VFC on inject, and creating a slick of silicone oil just posterior to the IOL. Now you can see this wave here. And then the backflush cannula, we sort of keep on as passive aspiration, as we keep that in the PFO while the assistant is holding the VFC, and the primary surgeon is going down on the pedal and actually injecting the PFO. And you just stay in the PFO the entire time, and it kind of, the IOP just equilibrates, that if the IOP is too high, that when you're in the PFO, it'll passively egress more out of your backflush. And so you can kind of see this edge here of the PFO, and then now there's just a little bit at the end.
So couple, why a direct exchange here?
It's nice because it reduces the chance of slippage. It's like what was under the PFO is not likely to move once you just directly exchange it for oil. It's not a big retinectomy, so you could probably get away with just going to air and then going to oil after that. But it was feasible. It was, you know, Prithvi is so good at it that it felt like it worked. So,
have people tried the active PFO, direct PFO to oil exchange? And if you do, how does it compare to?
Yeah. So
possibly?
yeah, I've done it, and I think I'm just used to doing this with the fellow, and I don't know. There's something about terrorizing the fellow, having them learn to do do it passively, but the active I think works pretty well, especially if you're by yourself. You do need I find that you still need that Med1 line that is for oil, because otherwise you can't just hook it. You have to trust someone would hold it at that point if you're trying to do it without an assistant. So you need that connector for Med1 that allows for oil infusion. But yeah, it's just a matter of the pedals. How does that work with the other systems, Sunil? Can you do the combined with the Bausch system easier than with the Alcon?
No, so you can, I mean, you have a dual function. You usually set up the pedal ahead of time to do both, but you can do both if you'd like. So you can go down with the VFC and then slide for aspiration if you wanted to. I still like doing it. I mean, I don't do these as much as I did when I was a fellow. I like doing air fluids, and I think the caveat I'll tell is when I taught one fellow in particular how to do this, we made the mistake of not seeing our infusion port very well. It was a case like this, and the infusion line was actually subretinal. So we flattened the whole retina, but we didn't get it all the way. So we actually had subretinal oil coming into the eye in the beginning. So that probably biased me enough. And the 3 hours later, after I got the whole thing flattened and taken care of, I decided any time I saved, I was better off just doing it this other way. Because there is something to be said about air coming into an eye and forcibly forcing the fluid posteriorly and being able to aspirate it out. So I don't know, I've gone back and forth in it, and I agree with you, Kapil. I think the slippage rates are probably lower, but I think if you carefully dry, I can see an argument for an air fluid.
I think like 7 hours in or whatever this was, like I don't want to sit and dry anymore. I just want to get it done.
So then we just close at this. So originally post-op month 4, I'll show you the photos in a second. We had subjected him to a series of methotrexate injections, but not quite as often as they're doing in the GUARD trial. Vision was 2200, pinhole to 2060. This was post-op month 4. And then this is a OCT showing he's attached. And this was post-op month 7, I believe, where this was about a month or so after, or 2 months or so after oil removal. So he's attached without any tamponade, and visual acuity pinholes to 2030. So he's doing pretty well. I just have a couple of just quick pictures, but I can sort of skip ahead of this, where the reason I love this case is, as I mentioned before, it was a great visualization of anterior loop and seeing this contracted vitreous base. And there was this one series that I thought was interesting where they had endoscopic videos of several of their PVR detachments, and they looked at about 70 eyes and saw what was a percentage of different configurations of how this anterior loop PVR looks like. And they said in about 63% of eyes, this sort of smooth, normal anterior gel is replaced by the sort of a whitish curtain of fibers that maybe it's this fibroglial proliferation that's causing this contraction that we know. And this was surprising to see this much percentage of ciliary detachment, at least in their series, of almost a third. And they note that this was sort of limited to the area of the RD. And one interesting thing, maybe they were just being advocates of endoscopic surgery, but they said that they were able to catch this because they were doing endoscopic, whereas if they were just doing scleral depression, you'd kind of be masking these areas of ciliary detachment because they're kind of pushing the eye wall up into the ciliary body. And these are kind of, the last one was 27%. They would see sort of pigmentation and white granulations. And this is just kind of a screenshot of their cutter tip and looking under it with endoscopy. That's it. And thanks to Prithvi for letting me go through that case.
Nice job. Great work. So we got 2 more cases. Hadi and Subin, Prithvi, I'll let you introduce them, but let's try to do this in 15, okay?
Go for it.
So Hadi Kapoor is our first year, soon to be second year fellow from resident at USC, and he's going to be showing us a IOFP case. He is currently looking for a job. So we'll see how he does.
No pressure, bro. No pressure. It's not like anybody's watching.
Hi.
All right, a couple slides here. Let me see. All right. So we had a 28-year-old male making repairs to his tractor at 11 p.m. In April, was trying to remove a strip screw by drilling it, and the drill bit shattered, and he felt it hit him in the eye. And here's the exam photo, if you can imagine it. Count fingers vision, IOP deferred, poor view posteriorly given the fact that the cornea, you see a semilunar full thickness laceration. The lens has been through and through violated. We can kind of catch a glimmer of a metallic foreign body in there. And the CT scan was confirmatory. So I'll switch to my video now. All right. So made a viscoelastic to stabilize the AC as we performed 10-0 nylon sutures perpendicular to each edge of the laceration. Having stabilized that for vitrectomy, to go ahead and take that lens out of our way so we can get a better view of what we're dealing with posteriorly. And so I found this, I haven't done this a lot at this point, and I found it kind of challenging sometimes to get the right angle of the cutter to clear out the view here. I'll go back and I'll do some more work on this later once we get all the cortical fragments out. Using a depressor to kind of help move it anteriorly to the mouth of my cutter a little bit, Q-tip as well. And now we're looking posteriorly. I'll freeze for a second just to show we have some fragments of the lens in the posterior pole. We see our drill bit just sitting there encased in vitreous. And so my first thought here was, I don't want this thing to fly around and cut or detach or anyways traumatize the retina. So my first move I'll start doing is to kind of segment it, if you will. Kind of isolate the vitreous so that when I go about clearing the rest of the vitreous in the vitrectomy, I'm not perturbing it. Here I am lifting the hyaloid. Again, 28-year-old gentleman, so it's down, it's a little more challenging. And so, of course, with the view, the central edema and the lacerations, challenging to work with that. I'm lifting it slowly here, coming up nicely.
Nice job, man.
That's pretty.
Yeah, well, I got lucky sometimes. And again, moving to our little danger zone area here, making sure that I'm trying not to pull on the vitreous as I'm clearing the area around it. And here I am trying, I think I'll do a little bit more lifting in this region as I try to catch the membrane. Here we are. And again, views were tough. I was always trying to work around this central laceration. And here I am performing core vitrectomy, kind of getting vitreous out the way.
How did you feel like you had to do anything to prevent like the IOFB from moving as you were doing the vitrectomy, like as you were lifting? Were you concerned, or as someone just put up there, were you going to think about putting something tamponade to prevent it from hitting the macula?
Yeah, so we definitely discussed it with my staff, Dr. Alex Yoon. If you, I don't know if this really counts or not. If you look at the fovea right now, I left a fragment of the lens over it, and so that's kind of like a little pillow I left, because I tried to segment around that vitreous just to make sure that I wasn't gonna inadvertently pull anything around it. So it was definitely in the back of my mind. And I think it wasn't as mobile as I was going around. And so I felt fairly confident I was able to lift hyaloid and perform my core, and then I start shaving what I can, just to kind of liberate the area and clear out the space. But I did leave that piece of fragment on purpose there, just because so far so good, the macula is intact. And so we're thinking about how we're trying to get this out, probably by manual technique to come in there. We still have some vitreous encasing the implant, the IOFB. So I wanted to have a cutter in my hand, and either magnet was a first thought, because I'm presuming it's a magnetic drill bit. So we put a chandelier in to allow for bimanual technique. Performed using keratome blade to create a wound in the cornea, so we could get ready to receive it, enlarge our wound to 20 gauge for the magnet. We also had the IOFB forceps on hand in case we need to switch to that, but we thought that this could be a little bit less traumatic. And there it goes. And here's my cutter ready in action to cut this free and get those last few remaining strands, do a 360 all around it, and it looked clear. Brought it up, and then now trying to figure out how big we need to enlarge our wound, because the wound I made seemed a little bit smaller. So we measured it kind of through the cornea and also the corneal lac, trying to create a better estimate or guesstimate. And so here I am enlarging my wound. And then we thought, well, what is the best instrument to receive this IOFB? It's actually a pair of hemostats, because we felt it had enough bulk and grip. Because the last thing we want to do at this point, which is very high stress, was drop this, right? Because it was dropping, it's landing on my macula, and we don't want that. So this is 1x speed, very carefully, handing it to myself, grabbing it. Okay, whew, got it. And here we go. We're safe out of the eye, atraumatically. So doing well so far. All we gotta do now is basically finish up the vitrectomy and close up. So we kind of narrow this a little bit, put our trocar back in to introduce our cutter, take my protection, and shave around, and kind of do a better inspection now, see if we have any tears or any breaks in our retina. Seeing none, we were worried about, going back to like stripping, taking the whole bag, for example. In this case, because it was a through and through violation and not a traditional phaco, there's no really a reason to keep any bag remnants. It could be sites or nitises, nidi for growth of PVR if this thing were to scar in the future. So I stripped as much as I can, and I found this possibly this second most challenging part of my case, just to take this out, but eventually got it out.
So
has.
Why not take it out? So Eddie asked a great question. Why not take it out of the sclera? So what's the challenge with trying to take it out through the sclera?
You mean?
So enlarging your sclerotomy instead of enlarging the corneal wound and trying to take it out of the sclera versus taking it out of an enlarged corneal wound. What's the biggest challenge of taking it out from the sclera?
I think the biggest challenge was a couple of things, at least I can think about, was one, it have to be a fairly large wound. I'm scared that given the morphology of the IOFB, that it might inadvertently hit other delicate pieces intraocularly on its way out. It's a blind maneuver. I'm kind of just pulling it out, and that maybe it feels secure. Plus, it would destabilize the environment of the eye a lot more, so that when I'm trying to get back in there to finish cleaning up, it would be kind of a more challenging situation, I felt.
And I think the angle is tough too, because unless you get it perfectly aligned when you first grab it, it's going to be at maybe not in the right angle. And then you're handing it off anyways to get it into the right position to minimize the size of your scleral wound. And it can get stuck there and more likely to drop too as you try to pull it out if you're not gaping the wound enough. So I think I really like the way you did it. I think it's great. And that's fantastic.
Can I ask a quick question?
This year.
Can I ask a quick question, faculty? Like what kind of IOFB forceps would you use? What do you like to use to grab these things out of the eye? Something like that's irregular like this. Do you have a favorite? Besides the hemostat, which you can't put through the.
I like the Dewan forceps. diamond reverse action to one so that they are closed when you're not pressing on them.
That's a really nice one. The other thing that I often find is in these cases is you're doing them not in your normal OR. And I'm like, oh, somebody found a forceps. Yes, I will take that forceps and use that forceps.
Yeah, I'll say that I've started using, there are like these 3 or 4 disposable Ilp Forceps Magnets that Bausch has that are really helpful for these. I actually keep a couple in my trunk of my car. And just in case, like, you know, when I get called in, I have them if I need them, because I agree with you, Kat. Sometimes you know, it always turns out you do an IFB, but somebody did the IFB the day before. So they're washing the mock. I like the Mockmore forceps. Those are like my favorite ones to use for these. Yeah, in the trunk of my car. It's a Tesla.
That's why no one can find any ever, because they're
no, these are disposable. It's disposable. I bought it my own money. But no, we have them at our county, and we're getting them at our Cole. But I find that having the disposable ones are nice because you know you have them in your OR. And the flex loop is
so a couple points here. Demos mentioned the MST forceps as a handoff. I think the hemostat was a bold move of the non-microsurgeon, but it worked great. But I wouldn't even have thought of that. I mean, that's just like a big instrument there, but that's a good idea. But I like the MST. That gives you a lot of, it's rigid and it gives you some good flexibility, but not taking anything away from what Hadi just did. One of the questions is also, is the flex loop to be able to put it through the loop almost and then kind of capture it is another option. So.
Yeah, I mean, I think this is also at the Metro Hospital. I don't think we have half the forceps we have at Cole. I mean, I just missed them. I was trying to do the pick, but you know, it seemed it was a pretty large piece that we saw on the CT, so we're worried that we wouldn't be able to get enough purchase. But I mean, I think looking back on it now, some of the other forceps would be great options.
Yeah, but you have all the disposable ones, so that's the thing. We do. Yeah, we have all the disposable IFB forceps. So you can and the reason why you use the hemostat is because Alex has done it before on a glass case, so he loves the hemostats. He's just taking out of the eye. He has like he's going to publish a series of hemostat. IFB, yeah. What a great case, man. Nice job.
Laser up the area of where we think the impact site was, and yeah, that's it. Closing up, suturing up, and that's it.
Patient, lucky to have you. That's good.
How do you do?
He's doing great. He just got his sutures removed, and cornea saw him. They think he might actually be able to escape without a transplant and just putting a contact lens on, or if he wants the lens, you can give him a lens. He's 20/25 with pinhole. So that's good.
That's a great case to end your first year on, man. Nice job, man. Good work.
And you did it in 10 minutes.
Quick case.
Excellent. Last question. The group has been using it as like a urology snare, like for stones. Has anyone made their own and done that in the heat of the battle? I haven't.
I think Danny, did you have the case?
I did it last year in my first year. It's very nice. You have to have an assistant who controls the snare, and then moving the snare in the eye is not as easy as it sounds. It took actually like quite a bit of practice to try to get the exact, because it's so fidgety. Just the smallest move in your fingers and the snare moves big time. So you have to really align it with the foreign object, line it around, and then your assistant has to have the correct timing to pull the snare and capture it. But we did it after a lot of missed attempts, and it worked.
Good stuff. So our last case of the evening, well done, Hadi, is back here from our Stanford group. So Edward Eddie Crote will give it to us, and Loshan, take it away.
Cool. Thank you, Prithvi. Let me share my screen.
While you're doing that, I'll mention that Eddie's graduating as well in this month and will be joining the Retina Consultants of Michigan in Grand Rapids with our good friend Tom Alberg and his partners.
So Hadi took a lot of my thunder here because I was planning on doing a case, me struggling with a modified Yamani because we didn't have max scripts, and doing the whole thing with Ilp Forceps. I thought that'd be entertaining, but the video somehow got misplaced. So we're gonna have another IOFB. This is a 21-year-old female. She presents trauma. She was shooting a gun into the ground, having fun during the holidays in Arkansas, if you wondered where. She actually presented 1.5 weeks post-injury. She felt like her eye was okay and she wanted to fly back. And her vision was 2800 and her IOP was 17. Let's get to the case. This is how not to celebrate the new year. We see a 1.5 millimeter IOFB. When I was first looking at this, I'll pause it here. It looked like there was a temporal corneal wound right around here, and then a hole in the anterior capsule, a cataract, and then you couldn't really see the posterior capsule, but the IOFB was visualized around here in the pars plana with a little bit of heme there, but no retinal injury or breaks or anything like that. So the goal was to take out the cataract first and leave the posterior capsule and as much of the anterior capsule intact as possible to try to plan for a sulcus lens down the line. So we're going with 23 gauge here, and we shifted our trocar inferiorly to plan for a possible sclerotomy in case we needed it. Stained with blue here, filled the AC with visco, and then avoided hydrodissection. Now here I'm doing the anterior capsulotomy with the cystotome, and it's going well, it's going well. I'm getting it around the hole there temporally. Everything looks fine. And then I come out, and then I start going with the INA. It's a very soft lens. And then come out, and the anterior capsule splits open just from posterior pressure, it seemed like. So I didn't see any vitreous coming forward, and so I continued just aspiration. There's a little air bubble back there. Maybe that was part of the posterior pressure. So now sutured the cornea and filled up, just kind of taking a look here and using the retractor to get the last little bit of lens there as the, I don't know if you guys can see around this, but as we didn't know if there was vitreous there, so just cutting with a retractor as well. And so there's an open temporal capsule now, and now we could see the posterior capsule as well. And there was a little hole in the posterior capsule nasally. So I was trying to go through my operative plan and think about how to get this IOB eventually. And the goal ended up being to take it out in the same trajectory that it seemed to have gone in, from temporal to nasal, and then had lodged in the nasal, in the nasal anterior vitreous. So that'll inform how we proceed here with the vitrectomy. So doing a little bit of core and getting the hyaloid up, as Hadi demonstrated, but I actually left the nasal posterior vitreous kind of as a column for support to keep the IOP anterior. And here's putting in some Kenalog and getting the hyaloid up. I love that no one's asking questions because Hadi took all of them. It's great.
No, I was going to ask you, actually, I was trying to be nice to you, but that's fine. So why leave so the downside, is there a downside to leaving the nasal hyaloid down or farther down than you normally would? Can I ask it that way?
Yeah, I guess the downside would be maybe we're predisposing ourselves to tears when we're manipulating the IOFB.
That's the only thing I would be concerned about here is that, I think you're in a higher risk situation because you can do a fair amount of manipulation, but I get it. I understand why you're doing it. But that's just something I'd be ready for, right? Once you engage it, to be ready to clear it.
Right. Yeah, that's a great point. And
yeah,
I thought
I don't necessarily see that much downside to letting it just drop.
I guess, the goal was to really go in that same angle, I guess, and using the hole, like the posterior capsular hole, which was nasal, as kind of the hole to go through in order to leave the posterior capsule as much as possible. I guess you could still do that if we went through a posterior approach and make a sclerotomy, but I was trying to avoid that if possible. So I've kind of cut the original corneal wound. Can you guys see around this thing? I don't know if you guys are seeing it or not. Here we go. So I cut the corneal suture, and then this thing kind of moved into position, and you can see it's pretty sharp and it's shaped pretty much the wrong way, or it's oriented the wrong way. But going through the original corneal wound, going through the anterior capsulotomy that I made, and then trying to go through that same hole in the posterior capsulotomy. And then I had the vitrector in behind it, so that when I grabbed it, I could clear it.
Nice.
That's smart.
That's really nice.
And so extended the wound a little bit and then brought it anteriorly, and it just kind of let it go because I knew it was in the wrong orientation, and then used the flow dynamics to just push a little bit, and it came out. So that was our bullet fragment there.
It's like solid gold.
Yeah, it was like a guillotine shape.
It's like a special New Year's bullet.
So then just cleaning up the nasal vitreous, and then went back again to make sure that we got the hyaloid nasally, especially put a little bit more Kenalog, and then realized that there was still another layer of hyaloid, which we wouldn't have known if we didn't love Kenalog so much.
Well, I feel like maybe you didn't show it in your video, but we didn't see like that same wave that we saw when Hadi induced the PVD. So I wasn't convinced first time around either.
Can we please not compliment Hadi too much? It's going to get to his head. Please, let's be done with this.
Already there. I'm sorry.
Yeah, I think that's probably why
you can tear him down tomorrow in the OR.
Hey Prithvi, have you, for your IFB cases like this, do you ever put on a buckle?
Not these anterior ones. I think if it's posterior, I'm really strongly trying to get a buckle on. But if it's truly an anterior wound, I probably not. And the back looks pretty good. If I'd have low threshold for lasering. How about you?
Yeah, I used to probably earlier on because I think we trained with Eric Postel, who really believed it, and then I probably kind of moved and shied away from it now for exactly the kind of the reason you said.
Yeah.
But I watch really carefully for a dialysis because I do think the manipulation anteriorly does make a difference in some of these young patients.
Now we're going more anterior to make sure there's no vitreous to our wounds, and putting in some tenos, closing all our sclerotomies. And then we let her heal for a little while, and then 5 months out now, she. Oh, let me grab this.
I was going to say, don't tell me she did it again.
She's doing it again.
5 months out, she got a sulcus lens, so we were able to maintain enough of the capsule through that technique. And she's post-op week 1 right now and pinholes to 2030, which is great. I was really happy. And so here's some papers about buckles about around the time of IOFBs. So there was one prospective study that showed it reduced post-operative RD rate from around 30% to around 6%. and another retrospective study showing that the prophylactic buckles had a 3% RD rate. And there's one more slide.
Did they discriminate in that paper between like what Prithvi was mentioning?
Yeah. So
Yes.
it was all for zone 2 or 3 lax. And so here, another paper with 19 globes where primary buccal patients had an average final vision of 2270, fewer subsequent RDs, and no complications associated with buccal placement. So thank you to Dr. Nguyen with the original surgery and Dr. Doe for doing the lens implant. Thanks, everyone.
Nicely done. Hey,
Lovely job.
Quick question before we finish. Anyone run out of their stock of 1000 Centistoke silicone oil yet?
We're lower, we're good. We just started ordering 5,000 probably when we got the word. So I recommend everyone ordering your oil now.
Thank you to Bausch & Lomb for keeping that stock alive. But I think that could be the first COBRA of next year. We'll be dealing with 5,000 oil because at least in this country we don't use it that much.
Yeah, with the new removal sets, though, for both, it's actually, you know, the high flow. I think they're, you know, it's pretty quick for those who never done it before. It's actually faster than you think. So, yeah, I would order.
We
your
just
oil
did one
now.
last week of 5,000 out from someone else. It was not that fast. It was
I think if you use the but I think if you use the proper, if you use the, and I know it sounds like, but Bausch has a high flow cannula you can get it out of. That works really nicely.
But if you're not expecting it, it is significantly slower, as Hong Ween can probably attest to.
That'll be interesting. So Sunil, when's our live session again?
So thank you, everyone. The live session September 30th at at American Academy of Ophthalmology. So that's Friday night. It's in between the first day of retina subspecialty day and second one. So we cordially invite all of you. You'll see it on our website. We'll get email blasts.
Sunil, will there be food?
There will be food, plenty of food for you, Prithvi. It's at the Wit Hotel, a pretty cool venue. It should be a really nice night. It would be great to see many of you, all of you. It's going to be a fun time. It's not going to be, believe it, Prithvi will loosen up a little bit. It's going to be kind of nice.
Sunil, will there be beverages?
There will be plenty of beverages, and I'll make a Shirley Temple for you. So don't worry about that.
Thank you. Excellent. I think it'll be great to see everybody, and you know, we'll present some cases, and we may have some guest faculty joining us too. So we'll see where the evening takes us. But hope you all can join us.
And just wanted to thank our incredible fellows. We put you on the spot for the past 12 months, and you've done a great job putting videos together. Thank you to our faculty mentors on the Cole side. It's been Kat, it's been Sumit on the Stanford side. Loshan, thanks, great job today. Caroline, thank you for all your help. And I think Hassan is on here somewhere around. I know on the chat way too much because he's driving around seeing detachments because Prithvi's here. Wanted to thank iVista again. We're going to start this up again in probably late August, early September. So look out for these meeting invites. If you have any comments, please feel free to email any of us. And finally, thank you again to Bausch for their support of fellow education. Prithvi, you get the last word, bro.
That's it. Have a great summer. Congrats to our graduating fellows, and looking forward to having you guys as friends and colleagues going forward. So good luck, everybody.
Congratulations, everyone.
Yes, congratulations.